at picking and understanding the more advanced disease. Now, I mentioned earlier, endometriosis usually is associated with a complex of symptoms, different types of pain, disturbances of bleeding, frequently extreme lethargy, especially at the time of menstruation, and all sorts of things like low-grade fever feelings, low resistance to infection, so coughing and sometimes getting the appearances of urinary tract infections. Gastrointestinal symptoms are greatly overlooked by gynecologists. Similarly for urinary tract symptoms, and of course there are sometimes genital tract bleeding disturbances, and we do know that sometimes women with endometriosis in unusual parts of the body can have bleeding from bizarre situations, such as coughing up blood once a month at the time of menstruation, or even having endometriosis on the pleura and developing a pneumothorax once a month. Real rarities that all the medical students know about, but when you encounter these, they can be difficult to deal with. So this brings me in the latter part of my talk to look at endometriosis and how we go about the potential of using medical management for controlling the symptoms of this disease. I'm not going to talk much about infertility because we believe there is very little place for medical management in women who wish to become pregnant at that particular point in time. So the best approaches for management of infertility are through IVF and its various other ART variations, or in some occasions undertaking certain types of surgery prior to moving to ART and so on. But with more and more experience in recent years, we're tending to move away from surgery, and we're tending to move to ART for infertility and medical management for prevention of recurrence of the disease following good quality previous surgery, or prevention in the very first instance where you suspect a woman may be developing it, perhaps because she's got a very strong family history. So I will from time to time mention prevention. So, management principles and endpoints of treatment. Obviously, symptom relief is a key part of this, and the major symptom that women find difficult to manage is pain. There are other symptoms, as I've mentioned. Infertility I've touched on, and I emphasize here the prevention of recurrence. But an important part of management has to be good quality analgesia in a way that the woman can understand, and hopefully that you can fit in to the particular cultural background and the healthcare system and what it allows you to do. And then, of course, we want to use hormonal suppression to minimize recurrence, to minimize further progress of the disease, and to help relieve symptoms. And surgical excision there may still be a significant role for. What about actual treatment? We're becoming more and more aware of the variability of this disease, and therefore the need to individualize your management to the particular woman who is sitting beside you in the clinic. And sometimes this may result in you just observing this woman and not particularly undertaking active management. Less and less is that likely to be our route these days, but sometimes there may be a place for it, and sometimes it may be a choice of the woman not to take whatever therapies you're offering her. Effective analgesia, and then we move on to the actual active medical therapies. Many modalities, which I will come back and talk about. There are now a large number of Cochrane collaboration systematic reviews looking at different approaches to active management of women using medical therapies. And there are some new and some exciting looks into the future for where we may be going with medical management. We are starting to look particularly at combinations of medical management and the fertility treatments I have touched upon. Endometriosis and pelvic pain, well, we know that the two are associated very often, but often that relationship is unclear. There are multiple other causes of pelvic pain, and they should not be forgotten, even though endometriosis, we believe in most societies, is the commonest form the commonest cause of pelvic pain in women in the reproductive years. But other causes are not uncommon and should not be forgotten. And most cases, interestingly, most cases of mild or minimal endometriosis are often not associated with severe pain. The deep invasive diseases, or the deep invasive types, the phenotypes of this disease, are the ones that are generally most painful and most tender to touch. Don't forget about the woman's sleep quality, something that we as gynecologists rarely pay attention to. Why should we worry about our patients' sleep? Well, it's probably part of the way in which their pelvic pain symptoms are enhanced. If you're short of sleep, if you have a chronic sleep debt, you tolerate pain much less effectively. You don't handle it in the same way. Chronic pain interferes negatively with the quality of sleep. Sleep disturbances contribute to the onset of pain, whatever pain that is, that includes endometriosis, and to a lowering of the threshold for pain perception at some body sites, and it probably includes chronic pelvic pain. Sleep quality was significantly poorer in women with endometriosis than in women without that disease, and there are ways in which one can approach this. Very little has been done in the field of endometriosis, but in other chronic pains, exercise usually helps. Sleep education, working out with the woman maneuvers that she can do that will help her to get in the right frame of mind to sleep and to stay asleep. And melatonin, that hormone from the pineal gland that some of us take for jet lag, melatonin may in fact improve sleep quality for women with endometriosis pain. Now, there's a lot of literature on treatment of pain in different ways. I want to start with a surgical treatment, even though my remit is to talk about medical management, because there is still uncertainty about how you go about managing the disease and minimizing the pain that the woman is experiencing. And this is the first study that was done in a proper scientific manner by Dr. Chris Sutton in the United Kingdom, published in 1994, and he did a double-blind, randomized controlled trial of laser laparoscopy with expectant management, which was just a diagnostic laparoscopy and recording of the appearances and the symptoms, and a third person who was blinded to what went on in theatre was the one who did the ongoing assessments after the surgery. So it was a properly done study. 63 women with pain and minimal to moderate endometriosis, a 6-month follow-up with another laparoscopy, and significant pain relief after the laser treatment in over 60% of the women, compared with around 20% of those who just had a diagnostic laparoscopy. And this pain relief persisted in 95% of those women who got benefit through to at least 1 year of follow-up. Interestingly, the least relief was obtained with minimal disease. And actually, the disease progressed in 35% of the untreated group. So this disease does usually benefit greatly, even in the relatively short term, from some approach to prevention of recurrence. This is using a standard pain score, a visual analog score on the vertical axis, before, at 3 months and at 6 months. The laser treatment was with the closed circles, the black dots. So on the left-hand side, you see the pain scores before treatment. They both come down, even in the expectant treatment group, come down at 3 months. That's the placebo effect. But the placebo effect tends to wear off in 2, 3, 4 months. And so by 6 months, there is no beneficial ongoing effect in the diagnostic laparoscopy group, but a further improvement in the group that had very careful laser laparoscopy. He then went on to look at the proportion of patients who had their pain symptoms alleviated. So on the vertical axis are the percentages of patients who got better in terms of their pain. And if we look across at the right-hand side, so if I can find the pointer, here we have the right-hand side with the hatched bar. This is the assessment at 6 months. 100% of the women with stage 3 disease, so this is relatively advanced endometriosis, 100% of those women got a significant improvement to that effective laparoscopic treatment. The stage 2 disease, that's the open bars. Come on, let me find this pointer. It's coming. We have stage 2 disease there. They improved, but not as much as the stage 3 disease. And if you look at the black bars, you see that those women with peritoneal endometriosis, stage 1 disease, relatively mild, even though they had troublesome pain, only 40% of them had significant benefit at 6 months afterwards. This is a difficult disease to understand, and we do believe that these 3 different types and different severity are in fact behaving differently. What about recurrences after surgery? The best surgeons used to say, all my patients get better and I can tell them that I cure them. Sorry, that's rubbish. Most cases of those particular surgeons was that they had emphasized to their patients so strongly that this particular surgery would be the answer to their pain, that when that pain came back relatively soon, they did not dare to go back to that same surgeon, and they go to somebody else. And so it's very difficult to get good follow-up. But there are a number of studies in the literature which show that it is much commoner than generally recognized. So there's a real need for active prevention of recurrence after good quality laparoscopic surgery. Nowadays, we generally go for excision rather than using vaporization with laser. Effective long-term follow-up is required, so you don't just see them at 6 weeks and then say back to your general practitioner. You see them at least occasionally. Dr. Paolo Vercellini has recorded recurrences as high as 15% per year after good quality laparoscopic excision, and no association of the rate of recurrence with the ASRM stage of disease or the active nature of the apparent lesions. Dr. Tandoy and colleagues recorded between 43 and 68% of women having had a recurrence of their pain by 5 years after their laparoscopic surgery. And the recurrence increased steadily with time after the surgery. So this is a disease which recurs pretty effectively and fairly quickly in most women, even after good quality surgery. Going along with this, management of the pain does require good quality analgesia. And this depends very much indeed on your healthcare system and the way in which you can approach this and work with pain clinics or other things in order to produce the most effective relief of pain. One of the things I'm going to talk to you about in terms of medical management of the patient with endometriosis pain is in fact getting the women settled on a constant dosage of a preventive hormone, usually a progestogen or a progestogen combination. And in those women, we can actually get the great majority well controlled, no matter how bad their disease was at the beginning. But from time to time, they start to get pain back again. And these appear to be flares. So you get a flare of the pain within a few days. And it's often triggered by some stress in their lives, but sometimes you can't identify what that stress is. But it usually is self-limiting within 2, 3, occasionally 4 weeks. And so somehow you've got to produce effective analgesia or further suppression during that flare. You approach chronic erratic pain in different ways. There's sometimes intermittent, predictable pain, sometimes at the time of ovulation, but of course very typically at the time of menstruation. Many women with disease close to the bowel, doesn't have to be on the bowel, but just close to it, can get troublesome bowel symptoms, painful bloating. Some women have to have a different wardrobe because of their bloating at the time of menstruation when they have endometriosis. And we're beginning to see that some women develop neuropathic pain, pain with damage to nerve fibers, which appears often to be related to multiple attempts at surgery. One of the other reasons why we should probably be trying to minimize the number of times that these patients come to surgery. Effective analgesia, well, we can initially start with the antiprostaglandin agents, the NSAIDs, usually using a double dosage for limited periods of time, and that often helps to get a flare under control initially. And sometimes we need to proceed to codeine, variants of the codeine family. Tramadol often again helps getting the acute flare initially under control. Perhaps further going to use of oxycodone, or even occasionally for the worst flares, morphine used on a very short-term basis. Neuropathic pain can be amongst the most difficult to manage, using drugs like gabapentin or pregabalin, and those tend to have more in the way of side effects, and women can frequently not tolerate them for long periods of time. And of course, occasionally for the worst flares, admission for intramuscular or intravenous analgesics. And sometimes we're seeing benefits in these situations with acupuncture or other physical methods, but many women don't get good responses to those, so it needs to be an individual exploration. So, what about the list of medical therapies? GnRH analogues have been used widely. We are using these less and less frequently nowadays. Danazol we used to use a lot when we had nothing else. It still is a really good drug to fall back on, provided that you keep an eye open for side effects, and particularly the more worrying ones with voice changes or hirsutism effects. But in Italy and in some places in Japan, they've been using vaginal administration of danazol, finding it has a much lower incidence of side effects. The combined oral contraceptive is used very widely. I don't use the combined oral contraceptive pill because I find it somewhat illogical to give estrogen to a woman who has an estrogen-sensitive disease. So I tend to use the progestogen side of things. And generally, I have used medroxyprogesterone acetate and norethistérone. Now we have Dienogest, marketed as Vizan, or in some countries Desogestrel, again marketed as a mini pill, but can sometimes be very effective in managing the ongoing pains of endometriosis, particularly once you've managed to deal with the acute initial pain, get that under control with a GnRH analog, perhaps danazol, and then maintain that with a progestogen. And I have, over the last 10 years, been moving more and more to use the delivery systems. The subdermal Nexplanon, or in some parts of the world, the levonorgestrel implants are available. They should work in the same way, although there's very little data. Or using intrauterine progestogen with the Mirena levonorgestrel system. But for the most severe diseases, most severe pains in these women who've tried a whole variety of different treatments and had some surgery, we see some of these really very difficult patient problems, and we have to use very much off-label approaches to try and understand how we can manage these pains without doing multiple surgeries and exacerbating some of the background of the lesions in these patients. And we've been moving towards particularly using combinations, using the levonorgestrel intrauterine system, either with the subdermal implant or using double Nexplanon, the double implant, or even adding 2 of those systems to some oral dosage of progestogen, which you can then, I guess, titrate, really, by increasing the dosage when a woman gets a flare. And we're going to be seeing much more written about these different approaches for the women with the most difficult disease. And at the bottom of my list here, you see the progesterone receptor modulators. And the progesterone receptor modulators are a very interesting group of therapies, which we're going to see more and more of in the next decade. I'm sure that many of you are aware that one of these, that is ulipristal, has been marketed in most countries in Europe and has been approved in the United States for treatment of symptoms with uterine fibroids. But ulipristal also usually has beneficial effects in managing the pain of endometriosis, and I'm sure we will hear more about that in years to come. I've mentioned the combined hormonal contraceptives, which are generally pills, but of course we have patches and vaginal rings as well, and I particularly don't like them for theoretical reasons. But in most combined pills, the progestogen component is much stronger than the estrogen component, and therefore it often works quite well for managing relatively mild or moderate pain, but less often the more severe pains. So, the progestogens, for many years I've used oral progestogens continuously, often for many, many years. I have about 100 patients who've had at least 8 to 10 years of being on oral progestogens alone, without long-term side effects, without effects on bone density, or any other obvious long-term problem. And many of those women became quite desperate when another doctor took them off that therapy, and their symptoms began to recur when menstruation started again. So there's no doubt that for many women with endometriosis, sometimes really quite difficult symptoms, you can usually, with a bit of variation in the dosages and how you go about managing this, get good control. This is the list that I've talked about already. A little bit of data. This is a study, 34 women in the United Kingdom, laparoscopically confirmed endometriosis, doing another laparoscopy later, and studying both their bleeding pattern and their pain. And you can see here the orange bars are the visual analog score of pain, so high pain at the left-hand side before the women had a diagnostic laparoscopy at which the levonorgestrel intrauterine system, Mirena, was inserted, and you can see that there is a very effective reduction in pain maintained over the next 3 years in the group. Didn't work for everyone as an individual, and some it worked brilliantly, even better than this. And you can also see there is a reduction in bleeding. So many of those women had very light periods, which was probably also beneficial in helping to manage the pain. Dr. Paolo Vercellini, who has contributed a great deal, many publications to the medical and the surgical management of endometriosis, he carried out a randomized controlled trial of expectant management or levonorgestrel intrauterine system insertion in women who were having effective laparoscopic surgery. And in his group in Milan, they have some very good laparoscopic surgeons who technically can do a very good job. There were 40 of these women. They were randomized to either having a diagnostic laparoscopy followed for 12 months, having laparoscopic excision followed by 12 months of observation, or they had laparoscopic excision and insertion of the Mirena device, and at 1 year there was recurrence of moderate to severe dysmenorrhea in 10% of the women who had the Mirena system in place, but in 45% of the women who did not have the Mirena inserted after their laparoscopic surgery. And there is now increasing anecdotal evidence that inserting